I'm Dr. Sonali Smith from the University of Chicago, and I'm here to discuss some of the advances in aggressive lymphomas that were covered at the ASH 2020 meeting. This was the first time ASH had a purely virtual meeting, and it was really hard not to see everybody, but it was also a great opportunity to hear all of the new data that's being presented. For this year, I thought there was quite a bit about aggressive lymphomas that I think will impact how we take care of patients going forward. Many new molecules and new approaches, and I'll touch on some of that. I will note that even though this is supposed to be on all of aggressive lymphomas, that's clearly a very broad topic, and I won't have time to discuss some of the advances in mantle cell, Richter's, or T-cell lymphomas, and hopefully there will be other short discussions on that. What I found the most exciting about ASH this year for aggressive lymphomas is that, we've known for a long time that this is a disease where we want to cure patients with diffuse large B-cell lymphoma. But clearly we don't cure everybody, and there are second and third chances if patients are good candidates for aggressive therapies such as auto transplant or even CAR T. This year I found more regimens being developed for people who may or may not be appropriate for CAR T or transplant. And this includes the bispecific antibodies, as well as some of the antibody-drug conjugates. And what's evolving, at least within the bispecifics, is that I think there's been two different groups of compounds that are furthest along. One is the anti-CD19 by anti-CD3. And then this year we heard about 4 different compounds that are anti-CD20 by anti-CD3. And all of these compounds are slightly different in their composition and in their delivery, but one thing they share is an emphasis on safety and tolerability as well as outpatient delivery. So of the 4 compounds that were presented, this includes the mosunetuzumab, which I think is furthest along and was presented last year as well, but also odronextamab, epcoritamab, and glofitamab. And all of these compounds do offer the opportunity for patients to eventually have outpatient delivery of a very potent bispecific antibody approach. And what's exciting is that that these compounds do have activity even in patients who have had a prior CAR T procedure, as well as the outpatient administration, which we've already talked about. And I think what's exciting is that the toxicity profile seems to be quite manageable. The cytokine release syndrome, neurotoxicity, and other events that require inpatient observation, for example, with blinatumomab, seem to be attenuated, at least with this new family of agents, and I look forward to seeing them being further developed. The other piece that I thought was very optimistic is that for some of the compounds, there is a suggestion that if patients go into a complete remission, that those remissions appear durable, even with a year or more of follow-up. So this is early going, but I am quite excited to consider that there are some non-aggressive options available for patients with relapsed and refractory aggressive lymphomas. And that really brings us to where I think the field may be headed, which is that the next layer is for us to understand who is or is not a candidate for aggressive therapy versus a less aggressive approach. And the second question might be, how do we sequence all of these new agents that are coming up? In addition to the bispecific antibodies, the other area that I thought was really promising is the availability of antibody-drug conjugates. So polatuzumab and BR has been FDA approved now for a year and a half in the United States, and we saw some more data about omitting the bendamustine. And I think seeing persistent activity and better tolerability is exciting. There is also Lonca-T, which is another antibody-drug conjugate that I think will be very helpful. And then we have tafasitamab and lenalidomide, which is not an antibody-drug conjugate, but uses an engineered anti-CD19. And all of these regimens that I'm listing are intended for people who may or may not be candidates for CAR T or more aggressive approaches. And I think the more tools we have, the better equipped we'll be to take good care of our patients going forward. So overall, I thought ASH this year was really wonderful in terms of the data that was presented for aggressive lymphomas that are relapsed and refractory. And I look forward to seeing all of these regimens as they develop and mature.